Hello everyone, how are you doing? This is Mikva Clinic by Dr. K. Today we are going to revise pneumonia in pediatrics. I have prepared this video based on the following references. The first one is Nelson Pediatrics 21st edition. The second one is WHO Pocket Book of Hospital Care for Children, 2nd edition. Pediatrics Hospital Care of Ethiopia, 2nd edition. MedStar Pediatrics 2nd edition, Farnos Pediatrics 1st edition, Dream Pediatrics 1st edition, Pediatrics and Child Health for Health Science students, Lecture Note 1st edition. So we will summarize all the information about pneumonia in pediatrics age group, which means the definition, etiology, epidemiology, clinical manifestation, investigation, management, complication, and prognosis from all these books. So you are not obliged to read all these books. By simply watching this video, you can get adequate information about pneumonia in pediatrics age group. Now let's come to the clinical presentation. Historically, symptoms and risk factors. These are the two important things that we should assess. The symptoms includes one is cough. Cough is the most common presentation of pneumonia in children. One thing we should know is any child below the age of 7 years will have a dry cough. They can produce sputum, but they can't expel it. So we don't expect sputum for a child less than 7 years. But for children above 7 years, they may have productive cough. So we may characterize or we may have the details of the sputum. But for children less than 7 years, we don't expect sputum because they can't expel it, but they can produce it. Don't forget this point. So cough is common presentation. The second one is fever. The fever can be high grade or low grade fever. It's not always true, but usually high grade fever is associated with bacterial pneumonia and low grade fever is associated with viral pneumonia. The third common presentation is dyspnea or difficulty of breathing or shortness of breath. So due to that shortness of breath, there will be increasing work of breathing, and they will have again fast breathing, especially pneumonia in neonates or newborns. They will chest focus infection. They will manifest with fast breathing, failure to suck, and they may have cough also. So fast breathing can be common presentation. Don't forget that fast breathing is subjective finding, and objectively by checking the respiratory rate we may identify the presence of tachypnea. So fast breathing, failure to suck is common presentation for neonatal age groups. And for older children, they may also additionally have abdominal pain, especially in case of lobar pneumonia. If it involves the lower lobe, usually they may present with abdominal pain and due to the irritation of the diaphragm. And the other thing is loss of appetite is expected because of release of those acute phase reactants. And older children may also complain pleuritic chest pain, which means they may experience chest pain while during inspiration. This is because of pleural irritation by the infectious agent. And the child also may have prior or recent history of upper respiratory tract infection because, as I have mentioned, viral infections will provide a fertile ground for bacterial pneumonia. So once we know these symptoms, we can suspect the presence of pneumonia. So we have to assess the second thing, which is the risk factors. Always don't forget that any child presented with pneumonia should have at least one risk factor because pneumonia is a preventable cause of death or illness in general. So the illness occurs due to the presence of one of the following risk factors. What are the risk factors for pneumonia? One is lack of immunization. It's common in developing nation. The second one is malnutrition. Malnutrition can be primary or secondary malnutrition. Primary malnutrition is one is from lack of exclusive breastfeeding. The other thing is due to inadequate complementary feeding. So always we have to assess the nutritional history of the child in detail. The second one is secondary malnutrition can result from chronic medical illness like asthma, congenital disease, or GI problems, cerebral palsy, and the like. So these problems may also lead to secondary malnutrition. So we have to assess historically the nutritional history of the child and and we have to go through the anthropometric measurements so we can discover the presence of any malnutrition and the cause of that malnutrition. This is the second important risk factor. The third one is indoor pollution. Especially in developing nations, the kitchen might not be separated from the living room, so the child is exposed to smoke which results from using combustion fuels, or sometimes parental smoking. If the father or the mother smoke cigarette, then the child will become passive smokers. All these problems will cause damage to the respiratory epithelium. As I have mentioned on the pathogenesis of pneumonia, pneumonia develops when those protective mechanisms are breached. So unhealthy epithelium or damage to the epithelium will cause or will provide a fertile ground for the development of pneumonia. So indoor pollution and parental smoking is third important risk factor. The fourth one is crowded living condition. Crowding has its own definition. WHO has its own definition. There is also American Crowding Index, which is used in America. In Canada, they have Canadian National Occupancy Standard and the like. So I will give you as an assignment to search or to read about the WHO criteria for crowding. When do we say certain living condition or the living condition of a child or person is crowded living condition? So it's good to know about this crowding index. So we have to assess the housing conditions, the door, the window, and the like. So crowding is very important risk factors in development of pneumonia. The fifth one is congenital heart disease, asthma, and sickle cell disease. All these problems, as I have mentioned, they will reduce the pulmonary functions of the child. So whenever the child develops infections, their pulmonary function is low, so easily they will become symptomatic, and it will predispose the child to have pneumonia. And there is also, even though the exact cause or the exact relation is not known, being male by itself is also one of the risk factors. And the other thing is vitamin D deficiency, because vitamin D is very, very important for healthy epithelium. As I've mentioned, healthy epitheliums are very important for the protection or for protection of the respiratory tract from infection. So vitamin D deficiency. How do we assess vitamin D deficiency? The most important thing is assessing the sunshine exposure of the child, whether he is exposed or not. If he is exposed to sunshine, then we have to assess the adequacy of that exposure, because vitamin D is produced by our body. What we need is ultraviolet radiation, UVB radiation. So we have to assess the sunshine exposure, and we have to include it in our HPI. The other thing that we have to the other important risk factor is low birth weight. So perinatal history is very important. If possible, the birth weight of the child, the gestational age at birth, all these things, knowing all these things is very important. Do you know why? Because lung is the last organ to be matured. Usually, premature children have the commonest problem which is seen on premature children is breathing difficulty, because lung maturation occurs lastly. So if the child came to this world before the right time, earlier than the right time, then the lung is not matured, so that will make them to suffer from breathing difficulty. The same is true. They have reduced pulmonary function, so whenever they develop certain infection, then they will develop or they will experience severe form of the disease. That's why we have to know that knowing the perinatal history is very important in assessing the risk factors. The other risk factor is immunodeficiency. Anything which can cause immunodeficiency predisposes to infection, because as I have mentioned earlier, the protective mechanism is associated with one with those immunities. The the production of immunoglobulins, the production of alveolar macrophages. All these are relevant for protection of the respiratory system. So if there is immunodeficiency from acquired causes like RVI or congenital causes like SCID or other immunoglobulin deficiencies, may predispose the child to have recurrent, in general, may predispose the child to pneumonia, and frequently associated with recurrent pneumonia. And the other thing, or the other important risk factor, is family, in the family members with upper respiratory tract infections. So in adults, they can easily handle the infection, but if there is any parent or if there is any family members with upper respiratory tract infection, they may transmit it to the child. So these are important risk factors that we should discover in our history. Every child developing pneumonia at least should have one of these risk factors. Don't forget this. After taking the history, we will proceed with a physical examination. Physical examination begins with general appearance. What do we expect on general appearance of a child presented with pneumonia? One is respiratory distress. So the child is expected to be acutely sick looking. Why? Because he's in respiratory distress. How do we know he's in respiratory distress? Because he might be grunting. Usually it is associated with impending respiratory failure. Don't forget this. Or the child may have nasal flaring. The child may have head nodding. Head nodding means movement of the head synchronous with inspiration. Or the child may have cyanosis in severe case. Again, it is a feature of impending respiratory failure. So this is the one which we expect in the severe form of pneumonia. Or child may also have might be chronically sick looking. As I mentioned earlier, malnutrition is one of the common risk factors for development of pneumonia. So acute sick looking in chronic phase is expected in a child with pneumonia. So after general appearance, we will assess the vital sign of the child. In the vital sign, we will expect on the respiratory rate, we will expect tachypnea. Don't forget that tachypnea is the most consistent feature of pneumonia. Tachypnea is the most consistent feature of pneumonia. So we have to count the respiratory rate for the full 1 minute. So the interpretation for tachypnea, it varies based on the age of the child. For the first 2 months, for the first 1 month, or for neonates, tachypnea is when the respiratory rate is above 60. And for children's 1 month up to 11 months, tachypnea is above 50, respiratory rate above 50. So from 1 year up to 5 years, above 40. From 5 years up to 8 years, above 30, and above, for a child above 8 years old, tachypnea is when the respiratory rate is above 24 like the adults. So after counting the respiratory rate, we will check the pulse rate. It is expected to have tachycardic because of the respiratory distress. And we have to measure the temperature. Clinically, historically, the child may complain, or historically we may get history of fever, but objectively we can measure that presence of fever using a thermometer. Commonly we use auxiliary temperature. Actually it's not the true recording of body temperature, but it's easy, so usually we use auxiliary temperature, and the normal range is 36.5 degrees Celsius up to 37.5 degrees Celsius. Don't forget that these measurements have diurnal variation between morning and evening. Up to 0.5 degrees Celsius variation is expected. However, we will consider fever for a child having temperature of above 37.5 degrees Celsius. Low-grade fever is considered when the temperature is between 37.5 to 38.4 degrees Celsius, and high-grade fever is considered when the temperature is greater than or equals to 38.5 degrees Celsius. So fever is expected for a child with pneumonia. The blood pressure of the child, usually it's normal, but if the child develops complications complications, systemic complication, if he develops sepsis and if he develops septic shock, and hypotension may occur, but it's not common. The other thing, the vital sign, we should check the saturation of oxygen. If we have pulse oximetry, then we have to measure the SpO2, and if the saturation is less than 90%, you have to rush to put him on oxygen. Don't forget this. You have to put him on oxygen whenever the saturation is less than 90%. So these are the things that we need to assess under the vital sign, and these are the things that we get or expect in a child with pneumonia. So then we have to check the anthropometric measurement. Anthropometric derangement may occur because of the malnutrition. So it's good to assess the anthropometric measurement. Then we have to examine each systems. But the most pertinent finding that we expect is on the respiratory system. Under inspection, we may get subcostal, intercostal, or suprasternal retractions. Chest lag is expected. And under palpation, chest lag can be seen because of development of complications like effusion, empyema. Then there is chest lag on the affected part of the lung. And under palpation, the trachea also may deviate. Normally, the trachea is slightly deviated to the right, but almost it's central. But in case of complications of pneumonia, like empyema, if massive effusion may push the trachea away from the affected side. So, assessing the tracheal centricity is good. Under percussion, we may get dullness because of parapneumonic effusion, empyema, which are complications of pneumonia. And sometimes we may get hyperresonant lung because of the development of complications like pneumothorax. Then auscultation. Under auscultation, we get cryptation on the affected lung. Don't forget that cryptation is a complication of commonly identified in bacterial pneumonia, especially in pneumococcus pneumonia. And wheeze because of narrowing of the airways, because as I mentioned in the pathogenesis, some of the etiologic agent causes respiratory epithelium to become edematous, that cause narrowing of the airway. So usually focal wheeze is we may get a focal wheeze rather than diffuse wheeze. And decreased breath sound in auscultation suggestives of empyema or parapneumonic effusion or pneumothorax. So usually they are associated with the complication of pneumonia. Under cardiovascular system, we don't expect that much special finding, but JVP might be raised. But we usually doesn't measure JVP in children. On the abdominal examination, there is one thing that we should know. On the abdominal examination, liver might be palpable, and it may seem like the presence of, we may consider presence of hepatomegaly, but it's not true. This is because in case of hyperinflation of the lung, especially in case of viral pneumonia, the hyperinflation will cause the liver to be pushed down, so it will be easily palpable. So we may consider as hepatomegaly, but don't forget, we should assess the total liver span. The total liver span will not be affected, it will be normal. So always measure the total liver span whenever you get palpable liver, because it's usually associated with a pushing effect of the lung. So it's normal to get palpable liver in the abdominal examination. On the central nervous system examination, child may get confusion or altered mentation in case of severe conditions of the pneumonia. So these are the physical examination findings that we expect in a child presented with pneumonia. So pneumonia is a clinical diagnosis. Underline this point. Clinically, just by sitting in your office, you can diagnose pneumonia. The presence of those symptoms, the presence of those risk factors, the presence of one of the following these physical findings. So compiling all this information, we can diagnose pneumonia. But occasionally we may need additional investigations to further confirm the diagnosis or to assess for the presence of complications. These investigations involves one is CBC, complete blood count. And from CBC, what we need is the WBC count. What do we expect? Since it's infection, leukocytosis, white blood cell count will be high. And we have to look for the differentials for leukocytosis. So the differentials, the differential means the presence of the granulocyte counts will be high in case of bacterial pneumonia, and the lymphocyte count or predominance is seen in case of viral pneumonia. Don't forget, it's not always true, but usually neutrophil predominance is seen in case of bacterial pneumonia. And the other investigation is ASR might be raised, so simply it shows you the presence of infection. And the other thing is we need chest x-ray. Chest x-ray again it's again based on indications. For the initial management of the child, we don't need chest x-ray. Chest x-ray is ordered when we anticipate complications, because those complications can be seen on chest x-ray. So what do we expect on chest x-ray? One of the typical findings is consolidation. Consolidation means, as you know, the alveoli are filled with air, so the lung is aerated. So that aerated part of the lung is replaced by a solid, semi-solid or fluid materials. Then it will become, or it will have the features of consolidation. As you can see on this x-ray, here is the consolidation. As you can see, here is the consolidation. This is the consolidation. So consolidation is the replacement of that aerated part of the lung is replaced by the fluid or solid. So the x-rays or the ray cannot easily or can't easily penetrate the lung. That will lead to the whitish appearance of that segment of the lung. So this is what we call it consolidation, and it's a typical feature seen in case of streptococcus pneumonia. Pneumonia caused by streptococcus pneumonia. So in case of viral pneumonia on X-ray, what do we get? Hyperinflated lung. Hyperinflated lung is expected. In case of complications, empyema, parapneumonic effusion, we get the presence of meniscus line or obliteration of costophrenic angle, suggestive of the presence of fluid or empyema within the pleural space. So complication can be assessed or diagnosed using chest X-ray finding. So these are the investigations that we do. Don't forget that the definitive diagnosis is done by isolation of an organism from the lung sample, which is invasive, which is impossible. Or from blood, it is possible, but only 10% are positive. And we can also isolate the etiologic agent from pleural fluid if there is complications like parapneumonic effusion, empyema, and the like. We may isolate the infectious agent from these samples. So in general, these are the investigations that we may consider while diagnosing pneumonia. So in general, to identify the etiologic agent is whether viral or bacterial, starting from the history and the physical examination, the clinical appearance, and those physical findings and investigations will give us a clue whether it's viral or bacterial pneumonia. But our concern or our focus is on bacterial pneumonia because it is the one that we are going to treat. Before discussing about the treatment, there is one thing we call it patterns of pneumonia. There are different patterns of pneumonia. Knowing these patterns of pneumonia will give us a clue on the underlying etiologic agents. So these patterns are about 5 patterns of pneumonia. The first is lobar pneumonia, when it is involvement of single lobe of the lung. As you know, the lung is separated, or each lung is divided into lobes. As you know, the right lung has 3 lobes, upper, middle, lower lobe. the left lung has upper and lower lobe. So specifically, when specific lobe is affected, we call it lobar pneumonia. Lobar pneumonia it's a classic features of pneumococcus pneumonia. And the other thing is bronchopneumonia. It is involvement of the airway and the surrounding interstitium, and commonly seen in Streptococcus pyogenes and Staph aureus infections. The third pattern is necrotizing pneumonia. It is associated with aspiration pneumonia, especially etiologic agents are anaerobes, and strep pneumonia, Staph aureus is commonly associated with necrotizing pneumonia. And the fourth patterns of pneumonia is caseating granuloma, which is special group, special patterns of pneumonia, especially associated with tuberculosis. The fifth one is interstitial or peribronchiolar pneumonia with secondary parenchymal infiltration. So it's seen in severe viral pneumonia complicated by bacterial pneumonia. So these are the things that we should know about the patterns of pneumonia.